Welcome to the American Lung Association webcast update with the CDC for chronic disease partners on COVID-19. Your first presenter today will be Deborah Brown, Chief Mission Officer with the American Lung Association. The webcast is being streamed through your computer. For the best audio quality, please make sure your computer speakers or headset are turned on and the volume is up so you can hear the presenters, and make sure you can see the media player on your screen. If you have any technical difficulties during the presentation, please let us know via the Q&A box. You may also ask questions through the Q&A box that will be answered either today or post this briefing. This webcast is being recorded and will be available one day after the webcast. It can be accessed using the same audience link that was sent to you earlier. And now we'll begin the webcast, and I'll turn it over to Deb.
Welcome, and thank you for joining today's webinar for chronic disease partners on COVID-19. As the oldest voluntary health organization in the country, the American Lung Association pioneered the model of using education, advocacy, and research to virtually eradicate tuberculosis in the United States. We will use those same principles to ensure our nation can address today's pandemic and is prepared to meet the challenges of the future lung infections like COVID-19. We are very fortunate to have an impressive group of speakers on this webinar, including two speakers from the Centers for Disease Control and Prevention who have important information to share with chronic disease partners on COVID-19. At this time, I will turn the webinar over to Dr. Georgina Peacock with CDC's COVID-19 response team. Dr. Peacock?
Thank you, Deborah. So thank you for including me today. As Deborah said, I'm Georgina Peacock, and in the COVID-19 response at CDC, I'm co-leading a task force that's called the Community and At-Risk Task Force. And typically at CDC, I'm the director of the Division of Human Development and Disability. I wanted to acknowledge people's anxiety around COVID-19. This is really an extraordinary, stressful time, and especially for those people who may be at higher risk. So I'm hoping that what we share on the call today will be helpful to you all. So I'll start first by sharing some background about coronavirus. This is a large family of viruses that causes respiratory illness, and it was first isolated in the 1960s. It's named for the crown-like spikes on the surface, and coronaviruses can spread among animals and people, and so we call it a zoonotic. As of note, there are 7 human coronaviruses, including the SARS-CoV-2, which is causing the COVID-19. This particular SARS-CoV-2 was identified in Wuhan, China in December of 2019, and early on, many patients were reported to have a link to a large seafood and live animal market. Later, patients did not have exposure to animal markets, which indicated that we then had person-to-person spread. And the first travel-related cases were reported in the United States on January 21st of 2020. The CDC is reporting confirmed COVID-19 cases in the United States, and as of today, we have about 658,000 cases with about 32,000 deaths. And I want to just acknowledge right now that these are really strange and humbling times, and send my condolences personally to those who've been affected by this illness and possibly by people you know that have died. On a slightly more positive note, I want to note that we do seem to have some slowing of cases in certain places, and many of the things that people are doing all across the country are helping to try to flatten that curve. And what we mean by flattening that curve, or decreasing the amount of illness that's occurring at any one time, is that we're trying to slow the spread of infections so that our healthcare systems and our critical infrastructure is available to serve the needs of the people that need that. And this is really being done by the work that everyone is doing related to physical distancing, staying home as much as possible, and taking individual measures like wearing those masks or cloth face covering. So symptoms may include fever, cough, or shortness of breath, and the estimated incubation period is 2 to 14 days. There's a wide range of illness severity that's been reported, from mild to severe illness, and as I talked about before, it can result in death. The complications may include pneumonia, respiratory failure, and multi-system organ failure. And it's important that if people develop emergency warning signs for COVID-19, that they get medical attention immediately. And these emergency warning signs include trouble breathing, persistent pain or pressure in the chest, new confusion or inability to arouse a person, and bluish lips or face. I think it's good for all of us to remember how we can prevent COVID-19. It's important to clean your hands often with soap and water for at least 20 seconds, or with hand sanitizer that contains at least 60% alcohol. To avoid close contact with people who are sick, staying home as much as possible, and putting at least 6 feet between yourself and other people. Covering your mouth and nose with a cloth face covering when around others, and washing that face covering routinely, covering coughs and sneezes, cleaning and disinfected frequently touched surfaces, and other precautions are really helpful for those that are at risk, including stocking up on supplies, avoiding all cruise travel as well as non-essential air travel, and calling your healthcare provider if you have concerns about COVID-19 and your underlying conditions if you're sick. So now I'm going to share some background on, now that I've shared background on COVID-19 generally, I'd like to discuss the work that the task force that I've been leading in the response does. And so this is called the Community and At-Risk Task Force. We're focused on populations that are particularly at risk, as well as focused on the communities in which people live. And we aim to reduce morbidity and mortality for those at risk by focusing on 3 categories of work. We're focused on people at risk for severe illness from COVID-19 because of underlying conditions, as well as older adults who are 65 years and older. We also focus on populations with different access, functional, or communication needs. And these may include people in certain racial or ethnic minorities, people experiencing homelessness, people with disabilities, low literacy, and those who may need different communication materials, such as those who use American Sign Language. And finally, we have a focus on social behavioral health and emotional well-being, focused on mental health, coping, and resilience, also looking at some of those negative indicators that are impacts of what's going on within this pandemic, such as intimate partner and domestic violence, substance use, and suicide. Community mitigation efforts are the things that we do to focus in communities like homes, schools, child care programs, retirement communities, and other different places like that. And so what we have on the CDC website is guidance about differences in these different places where people live and work that might have specific recommendations for controlling the spread. So here's a little more information about, based on the current science, the groups that we believe are at higher risk for getting sick from COVID-19. And you'll see here older adults, so those who are 65 years and older, and people with serious underlying medical conditions, including chronic lung disease or asthma, serious heart conditions, severe obesity, diabetes, chronic kidney disease, undergoing dialysis, and liver disease, and then people who are immunocompromised, including cancer treatment, smoking, organ transplantation, and those who have poorly controlled HIV or AIDS. A person who smokes tobacco products may be at greater risk and may have a harder time recovering from respiratory illnesses such as COVID-19. And cigarette smoking can suppress the immune system and also cause heart and lung diseases. Our teams work to get the information we need to make decisions and then get that information out to the people who need to make those decisions. So we use science, and we work with our epidemiology team to identify different community impacts and those who are at greatest risk or have other factors for concern. We also do monitoring and evaluation to assess whether the recommendations that we are making within communities are, how those strategies are working. Technical assistance to translate the findings into guidance and recommendations. Communication, and you may have seen a number of things in social media and other PSAs, other ways to get this information out to the people who need it. And then partnerships. So we use partnerships like this one to share our findings, to share our guidance, to share our tools, so that we can reach people in many different ways and get these important messages out. I did want to highlight findings from a CDC MMWR, which is a publication that comes out of CDC weekly, that was released on April 8th, 2020, which looked at hospitalization rates and characteristics of patients hospitalized with lab-confirmed COVID-19 during the period from March 1st to the 30th. I'd like to highlight that in this study, they found that hospitalization rates were highest among adults greater than 65 years of age. And then among adult patients with data that we had data on about underlying conditions, about 89% of them had one or more underlying conditions. Chronic lung disease was the most common, along with hypertension, obesity, diabetes mellitus, and cardiovascular disease. So these findings suggest that older adults have elevated rates of COVID-19 associated hospitalization, and that the majority of those hospitalized with COVID-19 have underlying medical conditions. And I think it underscores the importance of preventive measures, such as what I'd spoken about before: social distancing, respiratory hygiene, wearing cloth face coverings in public settings where social distancing measures are difficult. And we also need to protect older adults and people with underlying medical conditions, as well as the general public. CDC is a data-driven agency and continues to look at data from a variety of sources to inform our understanding of COVID-19 risk factors, including data from other countries, data from communities in the United States, clinical judgment from our experience with other respiratory viruses. COVID-19 is a rapidly evolving situation, and CDC continues to update information as it becomes available. So the best way to stay informed about people who are at highest risk from severe illness related to COVID-19 and many more other pieces of information related to COVID-19, the best place to go is the CDC's website. So this slide shows a few resources. These are different links that go to different places on the website. I will say that we are always constantly updating that, and so there is new information, as well as information on numbers of cases, numbers of hospitalizations. A lot of data is updated daily, and so you can go to the CDC website for that information. And with that, I would like to thank you for your attention, and I really appreciate being on the call to share this information with you. Thank you.
Great. Thanks so much, Dr. Peacock. With that, I think we'll turn it over to Dr. Brian King from CDC for his presentation.
Great. Thank you, Thomas. And I appreciate the opportunity to be here today, and I want to extend my gratitude to the American Lung Association for extending the invite to CDC to participate in today's webinar. I know there's a lot of questions about this issue, particularly in the context of smoking. Before I go into my presentation, I did want to reiterate a few points that Dr. Peacock nicely articulated. The most important of which is CDC is a data-driven agency. And so we base our recommendations to the public on the available science, and particularly evaluating the rigor of that science to ensure that our recommendations are based on the strongest available science to best protect public health. And I also wanted to reiterate again that this is a very rapidly evolving outbreak situation where you have a lot of new science that is emerging on a daily basis with hundreds of studies being posted daily, not necessarily all peer-reviewed on issues. And that can cause for some confusion if you have conflicting results from various studies, including around smoking. And so what I'm going to do today is articulate where we are in terms of the available science. And I think it's important to note that we can glean science from a variety of different sources, including some that have already been mentioned, including existing literature, such as the multitude of Surgeon General's reports that have been released over the past half century, articulating the inherent risks of smoking and how it affects the body, including on the immune system. We also do know that we have available science from other coronaviruses, including SARS as well as MERS, and what the experience of those coronaviruses are and what the potential implications could be with regard to the specific coronavirus that's responsible for COVID-19. And also we are seeing an evolving body of science that has been produced both internationally in certain countries that have faced peaks before the United States, including China as well as Italy. And importantly, now we're also starting to get some domestic-related science that can help further move the levers forward in terms of building a robust body of science to help inform public health policy planning and practice. So in terms of where I'm going to start today, it's really on this notion that when it comes to cigarette smoking, we have a robust body of science. We have the luxury of over 50 years of not only what risk factors are associated with smoking, but also what interventions and levers diminish and mitigate those risks. And there's not necessarily a lot of risk factors that have that luxury. But when it comes to smoking, we've released over 30 reports of the Surgeon General over the past 50-plus years, including available evidence on the specific health outcomes that are caused by smoking, including related deaths and disease. And so this slide articulates the fact that smoking harms nearly every organ of the body. And this is from the 2014 Surgeon General's report. And the health outcomes noted in red are the ones that were newly added in 2014. And that doesn't necessarily mean that they all of a sudden miraculously were associated with smoking. It was that we had sufficient science to, at that point, make causal conclusions related to their association with smoking. And I'll note at the very bottom of this slide, you'll see immune function was added in 2014 as being causally related to cigarette smoking. And there was three key conclusions that arose from the Surgeon General's report in 2014 around immune function and autoimmune disease. And they have very key implications when we're talking about COVID-19, particularly given the facts that Dr. Peacock has nicely articulated for us around people who have a suppressed immune system being at higher risk in terms of COVID-19, but also potentially diminished risk of recovering if they do contract COVID-19. So here are the three conclusions in the 2014 report that are very pertinent to this issue of immunosuppression. One, the evidence is sufficient to infer that components of cigarette smoke impact components of the immune system. Some of these effects are immune activating and others are immune suppressive. Two, the evidence is sufficient to infer that cigarette smoke compromises immune homeostasis and that altered immunity is associated with an increased risk for several disorders with an underlying immune diathesis. And then finally, the evidence is sufficient to infer that cigarette smoking compromises the immune system and that altered immunity is associated with increased risk for pulmonary infection. And so this is the one that's ultimately most pertinent to us here, and that we know that cigarette smoking diminishes the immune system, but also it's associated with increased risk of pulmonary infections, including respiratory illness. And so that has a very strong foundation of science over many decades of research showing that the biological plausibility is here. And that's important when we talk about causation when it comes to epidemiology, is you have to establish, is it biologically plausible for there to be a relationship here? And so now this slide gets a little bit further into the available science related to smoking and respiratory illnesses specifically. COVID-19 is a respiratory illness, and so we can glean from the available science the potential biological plausibility of how smoking could increase risk. And so when it comes to smoking and respiratory illnesses, a person who smokes has a greater risk of developing and has a harder time recovering from respiratory illnesses. This is very strongly evidenced in the available scientific literature. And we also know that smoking is associated with increased development of acute respiratory distress syndrome in people with risk factors such as severe infection, non-pulmonary sepsis, and also blunt trauma. And so this is also, again, helps to further support the relationship between smoking and respiratory illnesses, for which we have a strong available evidence base. Now let's transcend into the issue of smoking and coronaviruses. The available evidence does show, again, from other types of coronaviruses, that co-occurring in conditions including COPD, cardiovascular disease, and other respiratory diseases have been found to worsen prognosis in patients with other coronaviruses that affect the respiratory system, including those that cause SARS as well as MERS, which I'm sure you've already heard of in the news and elsewhere. But this, again, points back to that notion that we can learn from our previous experience with other outbreaks that have occurred globally. And now this last bullet also gets at an interesting component of how smoking is related to higher expression of angiotensin-converting enzyme 2, or ACE2. And you may have heard this in the media or elsewhere, but that's the receptor for SARS-CoV-2, which is the virus that causes COVID-19. And so I've included a little schematic on the right to make it a little easier for folks to digest, particularly non-scientists. And so you have the virus that causes COVID-19 on the left there, and you have the human cell in the pink. And so on the human cell, you have these various receptors, the ACE2 receptors. And so we know that smoking is related to higher expression of those receptors. And so if you have higher expression of those receptors, it's potentially higher risk for individuals who engage in that behavior. And that, in this case, it's smoking. And so we have a strong body of evidence showing that smoking is related to higher ACE2 expression. And we know from the available science that that is indeed also a receptor for the virus that causes COVID-19, which is also the case for other coronaviruses as well. So now let's go the next step further in terms of the specific studies on smoking and COVID-19. So I'm presenting just a selection of some studies that have been published in China, because that's really the area where we had the earliest onset of disease incidence, and for which there's been the most science and earliest science developed that help us get at this issue of the potential association and mechanisms related to smoking and COVID-19. And this is what the available science has shown from those preliminary studies. We know that a history of smoking was associated with COVID-19 disease progression among 78 patients in China who tested positive for COVID-19 based on nucleic acid detection. We know, again, that ACE2 expression was significantly higher in Asian smokers and Asian non-smokers from existing literature. And there's other studies that also found a non-significant trend towards an association with that it was observed between smoking and COVID-19 severity among 140 patients with COVID-19 in China. So this preliminary science is, again, suggesting, again, this causal relationship between COVID-19 and smoking in terms of not only risk of contracting, but also in poorer outcomes in terms of recovery among those who have already contracted COVID-19. So now let's get into the available science in the United States. The bottom line here is that the evidence is limited, but the good news is that it's growing. And frequently when you have these types of outbreaks, particularly for pandemics, people are initially in response mode, where you initially go into mitigation and treatment. And so it takes some time to stand up the research that subsequently follows in terms of evaluating key metrics. So the good news is that we're now getting to the point where we're building a large bolus of science and have data sets established to collect this information. For CDC's part, we're collecting data from a variety of avenues, including from case report forms from individuals with COVID-19, as well as clinical data from electronic health records, as well as other sources to help get at this issue of smoking more specifically. I will note that the study that Dr. Peacock mentioned before did assess smoking, and so I've noted a key caveat here, though, on the bottom of this slide, in that we didn't have sufficient sample to really say anything meaningful about smoking. And so it's a very important caveat is just because there wasn't an association found, that doesn't mean that it doesn't exist. And so for some underlying health conditions and risk factors, including being a current smoker, there was few outcomes that were reported. And therefore, we were very clear in that report that conclusions cannot be drawn about the risk for severe COVID-19 among persons in these groups. And so, one of the reasons why there wasn't sufficient sample here is, again, we're still continuing to get data in from the states, but we're hopeful that as we have more data available, it will help further refine the available science around this issue. In the meantime, we have to be very mindful of the existing science that is out there. There have been some studies that have been released, and they found either no association with smoking or even a protective effect with smoking. And so it's important to consider what the underlying factors could be that are driving that. And so remember what I said before, biological plausibility is a very important factor to establish causation. And given the long-established science showing the adverse effects of smoking on health, particularly around respiratory illness and also ACE2 activation, it's very hard to put any biological plausibility around a potential protective effect of smoking. And so what could be happening in these studies? Well, one is small sample. We know that there's still very small sample in some of these studies, and the smaller the sample, the lower the likelihood that you're able to effectively identify a valid association between two things. And so it's ultimately important that we have more robust samples that are able to really get at a lot of key issues, including being able to separate current and former smokers out separately to do more robust analyses. And another important factor with these studies is also what we call misclassification. And this is an important thing when it comes to epidemiology, and it's a fancy term. And basically what it means is you have to make sure that you accurately designate people into the group where they belong. And so some of these initial studies, because they have very small sample, they combine different groups. And so an example is combining never smokers with people with unknown smoking status. And so that's problematic because particularly with clinical settings, the people who say that their smoking is unknown, they could be misreporting because they're actual smokers. And so if you put all those people into an unknown box and then you combine them with never smokers, you're going to do what we call driving the estimate towards the null, which means you find no effect, or in some cases it could be so severe that it could find a protective effect, which is what some studies are finding. And so it's ultimately important to acknowledge that there's still science growing on this issue, but the biological plausibility is very strong for an association. And for the studies that aren't finding that association, it's important to look at methods to be able to see what's actually happening. And right now, we have a very strong biological plausibility based on existing evidence to indicate that smoking may increase risk of COVID-19 risk, but we still need more science, particularly U.S.-based studies, which are forthcoming on multiple fronts. So now let's go into the topic du jour of e-cigarettes or other vaping products. There's certainly been a lot of attention around these products for several years, particularly around youth and young adults. There's been some postulations that some of the variations in COVID-19 incidence among youth and young adults in the United States compared to other countries may be a result of several different things, including potentially e-cigarettes. The bottom line is we do not have science to suggest that is the case. We're still investigating the issue of e-cigarette use. As I noted before, we have several data sets where we're collecting information, and some of those also include e-cigarette use in addition to cigarette smoking. When it comes to e-cigarettes, we know that they do not emit a harmless aerosol. We know that it contains harmful or potentially harmful ingredients, including volatile organic compounds, ultrafine particulate, things that can be inhaled very deeply into the lungs and can be problematic for health. We also know that recently there was the national outbreak of e-cigarette or vaping product use-associated lung injury as well, which was linked to THC-containing products, specifically vitamin E, but is a type of lung injury that did occur that could increase, susceptibility to other respiratory illnesses. But when it comes to the issue of e-cigarettes, we don't have nearly as much robust science as we do for conventional cigarette smoking. Remember I said earlier, over a half century of science, very robust on cigarette smoking. There are some studies that have suggested that e-cigarettes may compromise the immune system and may have adverse effects in terms of damaging the lung in the long term. But the science is not sufficiently robust to make any causal inferences between e-cigarettes and COVID-19, either incidence or recovery at present. And so it's absolutely critical that we continue to get more science on this front. But there's certainly a far more robust body of science around smoking that can help us leverage the biological plausibility for COVID-19 than there currently is for e-cigarettes. This slide just shows that curve around EVALI, e-cigarette or vaping product associated lung injury. And as I mentioned before, when you do have a lung injury or existing damage, that can put you at increased risk for respiratory illness. So particularly for people with EVALI, there's potential for increased risk of COVID-19, but this is something that still needs to be investigated moving forward, and more science is needed. So when it comes to the key takeaways, this is the Cliff Notes version. So if I put you to sleep, you can rise from your slumber and get the key takeaways here. In terms of current CDC messaging, based on, again, the current science that we have, cigarette smoking can suppress the immune system and cause heart and lung diseases. 2, a person who smokes may be at greater risk for and may have a harder time recovering from COVID-19. 3, the relationship between the use of e-cigarette or vaping products and risk of COVID-19 is uncertain. And 4, most importantly, for help quitting tobacco product use or staying tobacco-free, call 1-800-QUIT-NOW or visit www.smokefree.gov. We have evidence-based resources, and now is a better time than ever to quit. And so it's critical as tobacco control entities that are working on the ground to capitalize on this opportunity, irrespective of COVID-19, but particularly now to leverage our cessation messages to promote the health of our nation. We do know that there's going to be a lot of benefits around this, particularly around risk of COVID-19 and smoking specifically. But we also know that there's a lot of anxiety in these times of that are occurring, whether it be natural disasters or other things that have occurred. We know from the available science that can increase smoking among individuals, and so now it's better than ever on multiple fronts to promote cessation of all forms of tobacco product use, particularly combustible cigarettes. So in terms of resources, this last slide just presents a lot of the materials that are currently available from CDC. As we've already heard from Dr. Peacock, there's great resources by CDC, www.cdc.gov/COVID-19. You can also do cdc.gov/coronavirus. They will both get you to the same place. And there's a lot of very easily digestible resources and information that folks at CDC have been working on for many months to help inform and protect the American public. And so, again, I'd encourage that you and your loved ones use evidence-based sources. And CDC is really at the forefront. We're working 24/7 with dedicated folks from across the agency to protect Americans from this health threat. In addition to the CDC resources, there's also federal resources, including coronavirus.gov, which articulates other efforts that are underway across the federal government. And then finally on the far left, how to quit smoking, cdc.gov/quit. There's a lot of great resources, and I'd be remiss if I didn't acknowledge that we're currently in the stages of another wave of CDC's award-winning Tips from Former Smokers campaign, which is both on the airwaves in terms of television and radio, but also digital media. And we're looking to potentially leverage tips to promote quitting messages, particularly in the context of lung illness and other factors that are especially pertinent to COVID-19. In addition, we've also created several references to smoking on CDC's websites around COVID-19. As Dr. Peacock noted, smoking is listed on the at-risk page, and there's also references around cessation, around the anxiety and stress page in the context of COVID-19. In addition to those, CDC will continue to leverage our social media and other messaging around this issue, again, based on the available science. And we'll continue to refine our messaging based on the science that is available. CDC Tobacco Free is on all major social media outlets. And we'll continue to advance a variety of different cessation messages on our website and elsewhere that you should feel free to look at and also leverage and promote. And we're also recently on Pinterest, so if that doesn't get you excited, I am not sure what will, folks. And so with that, I'm happy to turn it over to our next speaker.
Well, thank you, Dr. King. Hello, everyone. I'm Deb Brown, Chief Mission Officer with the American Lung Association, and I would like to highlight the key role that chronic disease partners can play during the COVID-19 outbreak and share some examples of activities that the American Lung Association has been doing during this outbreak with our constituents. As many organizations on this call know, the people that many of our organizations serve are at higher risk for developing severe complications from COVID-19. That means our organizations have an important public health role to play during this crisis, and our constituents will be looking to us for advice. While anyone can be infected by COVID-19, the effects of the pandemic do not impact everyone equally. The pandemic is exacerbating the consequences of racial and socioeconomic disparities in health and healthcare in America, creating a crisis within a crisis. We are seeing evidence of pronounced disparities in early reports on how African Americans in particular are weathering the pandemic. In Michigan and Illinois, more than 40% of the deaths are among African Americans, but the African American population only makes up 14% and 15% of the state populations respectively. In Louisiana, African Americans represent 70% of the deaths, but account for 33% of the state's population. These outcomes are in large part the result of longstanding inequities in health determinations, which include limited access to health care, especially primary care, and limited access to affordable housing and fresh foods. These have led to high rates of chronic illnesses like high blood pressure, diabetes, and renal failure that increase the risk of severe illness from COVID-19 among minority populations. Next, we have long known that quitting smoking is the single most important thing you can do for your health, and it's especially important now that during the COVID-19 outbreak, as both speakers shared during this presentation. While much less is known about vaping's relationship to COVID-19, for certain smoking and vaping cause health harm to the lungs, leaving lung tissue inflamed, fragile, and more susceptible to infection. In addition, tobacco use has been proven to harm the immune system and airway lining cells that contain cilia on their surface, which are essential defenders against viruses like COVID-19. Without them working properly, the lungs are more vulnerable. The Lung Association has long called for all public and private health care plans to cover a comprehensive tobacco cessation benefit as defined by the Public Health Service treating tobacco use and dependence. This benefit should be available to patients without barriers, ensuring tobacco cessation treatments are available during the outbreak could lower smokers' risk of severe complications and help protect family members from secondhand smoke during stay-at-home orders. Increasing access to and promoting these treatments are even more important now than ever. Maintaining funding for state tobacco control programs remains key to helping as many people as possible quit tobacco use. However, it is challenging in the best of times to protect funding for these programs, and with the COVID-19 outbreak, it is likely to get even more challenging. At this time, we've already seen several states reduce funding or in one case divert all funding to COVID-19 efforts. The American Lung Association thinks that states will need to be able to continue to address other public health challenges during this outbreak, and it will be crucial to maintain funding for tobacco control and other chronic disease programs. Last, several major pieces of legislation have passed related to COVID-19, and I want to take a moment to highlight a few of them. On March 6th, President Trump signed an emergency appropriations bill into law providing $8.3 billion for federal, state, and local public health responses, as well as additional funds for vaccine development. On March 18th, the Families First Coronavirus Response Act, which was the second supplemental package, was signed into law by the President. It expands paid and medical family leave for some employees and provides additional assistance for food programs and coronavirus testing. On March 29th, a $2.2 trillion bill was signed by the President. It includes more than $130 billion for hospitals, nursing homes, and healthcare workers, including billions for personal protective equipment. The National Heart, Lung, and Blood Institute received over $100 billion for COVID-related research. The American Lung Association is committed to working on this issue. We've submitted a number of letters to Congress and the administration about various COVID-19 related activities, including providing and improving the public health infrastructure. The Lung Association has a variety of channels that we have been using to share information on COVID-19, including a dedicated landing page on our website and our social media channels. Also, through our Each Breath blog, we feature timely articles each week written by volunteer medical spokespeople or editorial staff about lung health news and updates. COVID-19 has been the topic most discussed recently, and the three listed here are our most recent blog posts on the topic. The American Lung Association Lung Helpline is a free service staffed by lung health professionals that provides information to callers on many issues related to lung health, including tobacco cessation services. The Lung Helpline is a long-standing service, but we have used it as an additional outreach tool for constituents on COVID-19 during the outbreak. The Lung Association has a variety of online support communities for patients with lung disease that we are using to share information on COVID-19 with constituents. We have an Ask the Expert component to these online communities, and they can be especially important to maintain connections with others given the social distancing orders that are in place in most states. We are also doing weekly update calls with constituents who have lung disease on COVID-19 as an additional way to share information and maintain a connection. The calls are recorded and they're available on COVID-19 web pages that the American Lung Association has. Our organization has numerous free educational materials on a variety of topics related to lung disease that we encourage chronic disease partners to use. And last, I'm really pleased to share that the American Lung Association recently launched a $25 million initiative to end COVID-19 and defend against future respiratory virus pandemics. The COVID-19 Action Initiative will be used to expand the Lung Association's ongoing respiratory research program, enhance key public health measures, and establish an advanced network to stop future respiratory virus pandemics. You can find out more information about this initiative and ways to support it and be involved at lung.org. Thank you for your time today, and I'm going to turn it back to Thomas.
Great, thanks, Deb, and thanks to all of our presenters for some great presentations. We've had a lot of questions come in via the Q&A box, and I'm going to start asking those now. If you do have a question, please submit it by the Q&A box on your presentation screen. So this question is for Dr. Peacock or Dr. King. When do you anticipate the federal government releasing data about morbidity and mortality based on race, ethnicity, and gender?
This is Dr. Peacock. Currently, there is information posted on the website related to race and ethnicity. I think if you click on the cdc.gov, go to the COVID website, and you'll scroll down a little bit, and you'll see that there's different data tables, and there's information there.
Wonderful. So here's another question it might be for Dr. Peacock. Are people under 20 with chronic diseases like asthma at risk? COVID-19 doesn't seem to affect those younger than 20 as much as older people?
So I can start off and then maybe turn it over to Dr. King. We are definitely seeing more severe illness and deaths in people who are older, and then people who are older who have underlying conditions are at even higher risk. That doesn't mean that we aren't seeing any hospitalization or severe illness in younger people. We're just seeing that less. So certainly, I think the most important thing that if someone is younger and they have asthma, they should make sure that their asthma is well controlled and follow some of the prevention, activities that I shared earlier. Dr. King, anything else to add?
No, I think you hit it very nicely.
Great, thank you. Hold on one second here while I find it. So this is probably for Dr. Peacock and Dr. King as well. How is CDC reaching out to African Americans and other populations that have been disproportionately impacted by COVID-19?
So within the Community and At-Risk Task Force that I am co-leading, we have a team that is focused completely on minority and minority health. And some of our outreach, we have sort of a comprehensive outreach strategy. Some of that is through communication, so using different communication modalities as well as materials that will reach particular populations. And then we also are working through partnerships to reach people in different communities and related to different populations. For example, we did have a listening session earlier this week with the Martin Luther King III Foundation with some key African American stakeholders, and we're continuing to do sort of minority work in that way.
Great. Thank you. Dr. King, can you state the source again for the information on smoking and immunosuppression?
That would be the 2014 U.S. Surgeon General's report, the 50th anniversary report. You can get it at surgeongeneral.gov, or if you just Google 50th anniversary Surgeon General report, there's 3 major conclusions in that report related to immunosuppression in the health effects chapter. Great.
Another one for you while I got you on the line. You addressed e-cigarettes and cigarette smoking. What about marijuana smoking? Do these same implications that you shared apply?
Well, the bottom line is that whenever you light something on fire and inhale it into your lungs, there's going to be implications for lung health. And so in terms of the available scientific evidence on risks of marijuana smoke, it's not nearly as robust as conventional cigarette smoke, but it is important to remember that when you are inhaling things into your lungs, there are going to be implications in terms of risk. When it comes to cigarettes, we know that nicotine is the main immunosuppressive constituent of cigarette smoke. It's going to inhibit both the innate and adaptive immune responses, but we don't have as much robust science when it comes specifically to marijuana, so we're not able to make any specific conclusions in terms of increased risk of COVID-19 related to marijuana smoking. But the bottom line is, again, anytime you're assaulting the lungs by inhaling combustible smoke, there's going to be implications for lung health, which could lead to not only, respiratory illness, but other adverse health effects, including, potential implications for immune response.
Great, thanks for that. I'm gonna let one of my colleagues take over for a couple questions here. Anne?
Yeah, great. We've got a couple other questions that have come in. We've got one that says many people are running out of hand sanitizer and the necessary chemicals to make their own hand sanitizer. Are we okay with just soap and water and not touching our faces?
I think washing your hands with soap and water for 20 seconds or the time it takes to sing Happy Birthday twice, the Happy Birthday song twice, is a really good way to keep your hands clean. And yes, absolutely, practicing not touching your face is a really good thing to do too. I think many of us have figured out that we touch our faces a lot during this time, so that is another good reminder to not do that. Thanks.
Thanks, Dr. Peacock. We had another question that came in as well. What are the characteristics of children that are at greater risk for COVID-19 and severe complications of COVID-19?
We don't have a lot of information on that because, as you know, most children are not having severe illness from COVID-19. In that publication that we talked about earlier in the presentation, there was a little bit of information about children with underlying conditions, and it appeared that the majority of children that were hospitalized were those that had underlying conditions. I don't have the paper at my fingertips right now, so I don't remember exactly what those underlying conditions were, but certainly it looks like children who may be medically complex or have those underlying conditions are at higher risk for hospitalization.
Great, thanks. And then another question that came in, are hospitals required to document the smoking status of COVID-19 patients? And if so, will this data be made public?
So the way we get data differently through many different sources at CDC, and one of the main ways is by having health departments report that information to us, and smoking is included in that reporting back to CDC. So I don't know any specific requirements of hospitals doing that, but it is certainly something that is asked for on a number of different reporting forms.
Thank you. And I think Thomas has a couple more questions to ask now.
Great. So this is probably for Dr. King. Does nicotine itself suppress or otherwise affect the immune system in a way that can increase the risk of severe outcomes from COVID-19?
Yeah, so I got into this a little earlier in my previous response. Nicotine is the main immunosuppressive constituent of cigarette smoke. The available science shows that that's going to inhibit both the innate and adaptive immune responses. So that's an important, component. Of course, we know that nicotine is present in all tobacco products, including at potentially very high levels in terms of e-cigarettes. So there's a potential biological pathway there in terms of impact. But yes, the available science does show that nicotine does indeed have immunosuppressive qualities, and it is actually the main immunosuppressive constituent of cigarette smoke.
Wonderful. Hold on. See who's next. Let me try to figure out who's next here. So, I guess the question here is: Will there be a summary page with key takeaways, like what you had in your slide, Dr. King, that directly links to cdc.gov/COVID-19? Key takeaways on smoking. I think what the comment kind of expresses a benefit to having information like that to be able to link to and point to.
Yeah, sure. So I will reinforce that smoking is on several areas of our COVID-19 page already, including the at-risk page that Dr. Peacock noted before, as well as an area promoting cessation related to anxiety and stress around the current pandemic. So there is direct references of CDC acknowledging smoking as a risk factor that puts people at increased risk for more severe COVID-19. That being said, we're also doing a lot of things to get the message out, including this webinar. So the information that we've shared with you today is public, and so these slides are now accessible, and the messaging that has included them, including the key conclusions that were included in my portion of the presentation, are now available. As I noted earlier, we're going to continue to refine our recommendations and messages based on the available science. So as the science develops, we'll continue to upload that on the cdc.gov/COVID-19, including any potential modifications to the at-risk page that may be warranted based on the available evidence. But in the interim, you're certainly fine with using the content that we've presented to you today, and these slides, I believe, will be made available to the audience for use for any respective purposes that you may need in that regard.
Great, thank you. Are there data available within Asian Pacific Islanders and or the LGBTQ community about COVID-19?
I can't recall whether or not Asian and Pacific Islanders are included on the summary slides, summary tables that are on the CDC website that are updated every day, but that would be a good place to look. I'm not aware of any data that we have on LGBTQ. However, within our task force, we are thinking about sort of communication and outreach strategies to this population as well as many other populations. And so, you know, that work is being done in different ways, but I'm not aware of any data that we have.
And this is Brian. The only thing I'd add is that it's important to look at the smoking rates among some of these populations, again, to look at this biological plausibility and potential burden. And so the available science does show that markedly higher rates of smoking, particularly among the LGBTQ population, nearly, several-fold higher than what we see in the general population, and depending on some estimates, nearly double. And so there's certainly higher rates of this risk factor among that population. And also remember that people who are immunocompromised are also at potential increased risk. And being immunocompromised can take many forms, including those with poorly controlled HIV or AIDS, which we know has implications for some in the LGBTQ community as well. And so looking through the different risk factors that increase risk for COVID-19, it's important to align those with some of the potential increased risk factors among certain populations. And so that certainly includes LGBTQ when it comes to smoking, but also other factors that may contribute to immunosuppression.
All right, and this is going to be the final question. So should we promote non-nicotine medications instead of combination NRT this time, with nicotine impact on immune function?
Absolutely not. Absolutely not. Under no circumstances should we be preventing the administration of any form of FDA-approved medications. We have decades of science from randomized clinical control trials showing that these interventions are effective and safe. And it's important to note that the way that nicotine replacement therapy works is to effectively wean people off of nicotine over time. And the intent is not to be on in perpetuity, and it's also not necessarily the same massive amounts of nicotine that you'd be exposed to through conventional cigarettes or e-cigarettes. So when it comes to the current situation now is better than ever to quit. And we have an arsenal of 7 FDA-approved medications in addition to behavioral counseling. And when you use them together, it increases the chances that you'll quit even further. And we also have the National Quit Line portal, 1-800-QUIT-NOW, that can get people not only behavioral counseling, but also in some instances access to free nicotine replacement therapies. So we should be full steam ahead, folks. We do not want to backtrack on our evidence-based recommendations. And nicotine replacement therapies, including all 5 currently recommended by the FDA, are still proven effective and even more effective when combined with counseling to help people quit for good.
And with that, I think it's a great ending to this webcast. We really appreciate all the speakers and all the information that was shared. I know there were a lot of questions we couldn't get to, and I'm sorry about that. But we will try to follow up on those as we are able to. So thank you to everybody who attended the webcast.